Imagine you go to your doctor for a routine checkup. Nothing is wrong. You feel fine. No chest pain. No shortness of breath. Your blood pressure is normal. You are not overweight. You exercise. The doctor runs your numbers, looks at the screen, and says, "Based on the new guidelines, I'd like to put you on a daily medication, a cholesterol drug. You'll likely be on it for the rest of your life." You ask what changed. The doctor says, "The guidelines were updated." You ask who updated them. That question has a very specific answer. And the answer is the entire story. So, before you get comfortable, let me know in the comments where you're tuning in from, and take a moment to like and subscribe, but only if you genuinely find this worth knowing. In November 2013, the American College of Cardiology and the American Heart Association released new guidelines for who should be prescribed cholesterol-lowering drugs called statins. Before those guidelines were published, around 43 million Americans were eligible for statin therapy. The morning after they were published, that number was 56 million, 13 million new patients. Overnight. Not because 13 million people developed new conditions. Not because new science discovered a new disease. Because a committee rewrote a document. That's exactly what we're going to find out today, right here on Pharma Facts. To understand what happened, we first need to understand what statins are and why they matter. Statins are a class of drugs that lower LDL cholesterol, the kind commonly called bad cholesterol, by blocking an enzyme in the liver that produces it. They have been around since the late 1980s. They are among the most studied drugs in medical history. And for a specific group of patients, the evidence is clear and strong. People who have already had a heart attack or stroke. People with established cardiovascular disease. People with extremely high cholesterol levels. For those patients, statins reduce the risk of a second cardiac event significantly. The data on that is not seriously disputed. The controversy is not about those patients. The controversy is about everyone else. The healthy 55-year-old. The person with slightly elevated cholesterol but no history of heart disease. The people who, before November 2013, were told they did not need medication. Those are the 13 million people who appeared overnight. Here is how the 2013 guidelines worked. And this is the mechanism that almost never gets explained. The previous guidelines gave doctors a specific number. If your LDL cholesterol was above a certain level, you got a statin. Clear. Simple. Measurable. The 2013 guidelines abandoned that number entirely. Instead, they introduced a new calculator. The pooled cohort equations. A mathematical formula that estimated your 10-year risk of a cardiovascular event based on multiple factors: age, sex, blood pressure, cholesterol, smoking status, diabetes, race. If that calculator said your 10-year risk was 7.5% or higher, the new guidelines said you should be on a statin. Not if your cholesterol was above a threshold. Not if you had symptoms. If a formula said your statistical risk was above 7.5%. That sounds reasonable. Until you look at what the formula was actually doing. Within weeks of the guidelines being published, two Harvard researchers, Paul Ridker and Nancy Cook, ran the same pooled cohort equations on 3 large, long-running U.S. health studies. Real patients. Real outcomes tracked over years. What they found was striking. The calculator was overestimating risk by 75 to 150%, roughly doubling the actual observed rates of cardiovascular events in those populations. Their conclusion, published in The Lancet, was direct. As many as 40 to 50% of the 33 million middle-aged Americans newly targeted by the guidelines did not actually have risk levels that crossed the treatment threshold. The calculator that triggered 13 million new prescriptions was systematically overstating the risk those people actually faced. Now here is where the story takes a turn that rarely gets reported. Who wrote these guidelines? The committee was 15 doctors and researchers, chaired by Dr. Neil Stone, a professor of medicine at Northwestern University. The guidelines were produced under the umbrella of the American College of Cardiology and the American Heart Association, two of the most respected medical institutions in the country. But the British Medical Journal reported something specific about that committee. Of the 15 members, 8, including the chair and co-chairs, had current or recent financial ties to pharmaceutical companies that manufactured statins. 8 of 15. The ties were disclosed. They were not hidden. They were listed in an appendix attached to the published guidelines. But disclosed is not the same as absent. And the Institute of Medicine, the independent scientific body that sets standards for medical guideline integrity, had recommended that chairs of such committees should have no conflicts of interest at all, that at least half the members should be free of industry ties entirely. The cholesterol committee met that threshold by one person. Now, the committee chair stated publicly that any previous financial ties were in the form of speaking fees, and that he had severed connections with pharmaceutical companies years before the guidelines were finalized. And the guidelines themselves went through independent review. The science was vetted. The process had safeguards. But here is the question the data forces you to ask. A new calculator, later found to overestimate risk by up to 150%, expanded the statin-eligible population by 13 million people overnight. Those 13 million people would be taking drugs manufactured by companies that had financial relationships with the people who designed the calculator. And those companies stood to gain billions of dollars in new prescriptions. That is not a conspiracy. All of it is documented. All of it was legal. It is simply a question of who benefits, and whether the people making decisions were the right people to be making them. Now, to be fair, and the data demands fairness here, statins do work. For people with established cardiovascular disease, the evidence for statins is among the strongest in all of pharmacology. A large meta-analysis found that statins reduce the risk of non-fatal heart attack by 38% compared to placebo in that population. And the side effects, while real, are frequently overstated. The genuine risk of serious muscle damage from statins is extremely rare, estimated at a few cases per million patients. Muscle pain is reported more often, but studies have found that some of that reporting is what researchers call the nocebo effect. People who read about a side effect are more likely to experience it, even when taking a placebo. Statins, for the right patients, are genuinely beneficial drugs. The question the 2013 guidelines raised, and that researchers are still debating, is whether the definition of the right patients was expanded beyond what the evidence justified, and whether the tool used to make that determination was accurate enough to trust. A Harvard study published in 2024 found that using a newer, more refined risk calculator would reduce the number of Americans recommended for statin therapy by an estimated 14 million people compared to the 2013 guidelines. 14 million. The same scale as the original expansion. In the other direction, here is the number that ties it all together. Statins are among the most prescribed drugs in American history. By the time the 2013 guidelines were published, they were already a $20 billion annual market in the United States. The patents on the original blockbuster statins, Lipitor, Zocor, had largely expired by then. Generic versions were cheap, but the guidelines also created a downstream market. More patients on statins meant more patients experiencing side effects. More patients needing monitoring. More patients eventually being moved to newer, non-generic alternatives. And more patients primed for the next generation of cholesterol drugs, newer, more expensive, still under patent. The 2015 approval of a new class of cholesterol drugs called PCSK9 inhibitors came just 2 years after the expanded guidelines. Those drugs carry list prices of over $5,000 per year. The expanded statin-eligible population was, among other things, a market that had been prepared. A U.S. Senate Finance Committee investigation found that pharmaceutical companies spent billions lobbying medical guidelines and professional organizations in this period. The American Heart Association and the American College of Cardiology, the two bodies that published the 2013 guidelines, both received substantial funding from pharmaceutical companies. That funding is disclosed. It is legal. And both organizations argue, with genuine force, that their scientific processes are independent of their funding relationships. But here is what the BMJ, the Lancet, the Harvard researchers, and the New York Times editorial board all noted at the time of the guidelines release. When the people writing the rules have financial relationships with the companies that benefit from the rules, and when the rules are later found to be systematically overstating risk, the question of independence is not unfair to ask. It is, in fact, the only responsible question. Here is the number to carry with you. 13 million. That is how many new patients were created overnight by a guideline change in November 2013. 75 to 150%. That is how much a Harvard analysis found the guidelines risk calculator was overestimating cardiovascular risk in real populations. 8 of 15. That is the ratio of committee members with disclosed financial ties to statin manufacturers. And 14 million. That is how many fewer patients a 2024 study estimated would be recommended for statin therapy if a more accurate risk calculator had been used from the start. None of these numbers are hidden. All of them are in the published literature, the Senate records, the BMJ, and the Lancet. The question is simply whether the people who should have been asking them were the right people to be in the room. That is not an opinion. That is what the data shows. Statins have saved lives. That is documented. That is real. And the 2013 guidelines have been revised. The 2018 update added more nuance, more shared decision-making between doctor and patient, more tools for risk stratification. But 13 million people were handed a prescription based on a calculator that was later found to be wrong. Some of those people took drugs they may not have needed. Some experienced side effects. Some are still on those drugs today. The story is not that statins are bad. The story is about who decides who needs them, and whether the people making that decision were free to make it cleanly. This channel exists to follow the data, trace the money, and explain exactly how these systems work, in plain English, without the spin. If that is the kind of story you want to understand, subscribe. I'll see you in the next one.